Well, welcome everybody to the public board meeting of NHS England. Apologies for absence. We've got Julian Kelly is away and Munir Mohammed is also away. I hope this may be our last meeting virtually. I hope maybe in March we'll be able to work. We'll all be able to meet together again. But in the meantime, I'm afraid we've had to exclude members of the public from coming here for a physical meeting. Are there any declarations of interest that are not already declared that anyone would like to raise? No, thank you. And can I approve the minutes of the meeting held on the 27th of November? Good, thank you. Well, we've got a fairly short meeting today because clearly, obviously, the executive team have been very heavily engaged in the Omicron, dealing with the Omicron pandemic over the last couple of months. But I hope at the next meeting we'll have some more sort of substantive strategic issues on the agenda. But Amanda, over to you for your report, please. Thank you.
Thank you, David. And needless to say, it has been an extremely pressured couple of months since we last met. The NHS declared a level 4 national incident on the 13th of December in response to the new challenges posed by the Omicron variant. And in the face of that pressure, and thanks, I have to say, yet again to an incredible response from NHS colleagues, our partners, and of course volunteers, we have achieved some real successes. The COVID-19 vaccination programme was significantly sped up to provide the maximum possible level of protection to the public ahead of the anticipated peak in infections. And indeed, between the incident declaration and the end of the year, almost 9 million additional booster and third doses were administered, and now more than 4 in 5 eligible adults have received a third or booster dose. Just worth noting that over 550,000 of those were co-administered with flu. So that is a real positive given the logistical challenges of doing that, the COVID vaccine and the flu vaccine together, but it really does show the commitment to making every contact count. We also began the initial phases of rolling out the COVID-19 new treatments, so monoclonal antibodies and antivirals for those in the highest risk groups, and that was through new COVID medicines delivery units. And now more than 10,000 people have benefited from these treatments. We did a huge amount of work to create capacity ready for a potential surge in patients needing hospital care. Now, that was both in terms of providing support to leave hospital, but also creating additional capacity through things like the Nightingale Surge Hubs and the arrangement the Secretary of State directed us to make with independent hospital chains. Discharge, as you know, has been a major focus, and we've provided support through a range of actions, including the national contract with Hospice UK to support up to 4,800 people per day in hospice beds or their own homes, funding to pay for the use of beds in hotels, care homes, and increased use of the virtual ward model and COVID oximetry at home. We did see a really strong start with more than 56,000 people supported to go home for Christmas over the 5 days immediately beforehand. But of course, we do all know that making the kind of sustained headway we all wanted to see has been really hard, partly due, of course, to the significant capacity constraints caused by some of the impact on staff as a consequence of COVID, and some of those capacity constraints also in social care, with lots of regions reporting most or indeed a significant proportion of care homes and domiciliary care providers not being able to take on new people over that period. Staffing issues, as I said, were obviously seen across the NHS, with Omicron being responsible for more than half of all absences in trusts in early January, which is well over 1 million days lost in total just in secondary care. And we know, of course, that primary care teams have faced similar issues too. We've talked before about demand for urgent and emergency care and the impact of constraints on capacity and on patient flow through hospitals. We have seen real pressure, particularly on ambulance services, on response times in particular, and on A&E departments. That is a continued national focus, and we're supporting the NHS to improve with some encouraging signs actually in the last couple of weeks. We may want to talk more about that. But in spite of that very significant pressure, and thanks to the measures put in place since previous winter wave, early indications suggest we have seen elective and diagnostic performance maintained at higher levels than last year through December and into January. And that builds on the positive position we saw in the published statistics for November, which showed elective activity 13% up and elective procedures up 8% on November 2020. We've also continued, despite all of that, to work to make the best and latest treatments available to NHS patients. Over the past 2 months, agreeing deals to provide sapropterin to all PKU patients for the first time, Palforzia, which is a pioneering treatment for peanut allergy that will benefit thousands of children and young people. And that is on top of over 1,000 more children living with cystic fibrosis being able to access Kaftrio thanks to our existing portfolio deal after MHRA extended the licence. So look, once again, I just want to put on record my thanks to every single member of the NHS team who has worked so hard and with such dedication to care for patients and pull out all the stops once again to do so, and particularly for those for whom doing so meant sacrificing time with their families over the holidays. And just a particular thanks also to primary care colleagues. They delivered almost 7 million jabs in December and of course continue to work to ensure routine services are available as well. As we look ahead, the indications do suggest that the Omicron wave is beginning to subside, although significant challenges still remain, of course, beyond just the numbers in hospital. As Steve said this morning, in response to the latest weekly performance data, pressure on urgent emergency care pathways, on ambulances, flow through hospitals is still very high. And of course, we do need to continue to build on the work that we did on discharge, but also the early work of the Health and Social Care Discharge Task Force, and on the great work that Pauline has been doing with regional teams in particular to try and make sure people can get the right help in the right place at the right time. Maximising staffing capacity is going to be crucial to this, and thankfully COVID absences are falling from the very high levels seen in the 2 weeks following Christmas, but they are still causing concerns and issues for many services, so we do continue to work, particularly with 111 and 999 services, on recruitment. Alongside that, we're supporting NHS organisations in implementing the government's COVID vaccine mandation policy, called VCOD for short, vaccination as a condition of deployment. Vaccination among NHS staff in general is very high, with over 91% of those with an ESR electronic staff record having had at least 2 doses recorded, and a higher proportion of staff double jabbed than the rest of the population. And numbers of unvaccinated staff are reducing every day due to the incredibly intensive work that's happening across the NHS to support people to get the vaccine. But there will be geographical and clinical areas where we will need to support organisations and systems to mitigate the likely impact of implementing VCOD on service continuity and on recovery plans. On recovery, as I've said, we've seen some really great work to keep elective and cancer services going over this winter, thanks to a combination of continued prioritisation, protection and separation of elective care pathways, use of the independent sector, and benefited, of course, from relatively low numbers of COVID patients requiring intensive care. However, elective activity is obviously not the only area impacted by the pandemic, and we do recognise the importance of the focus on recovery across all our services, including mental health and learning disabilities, community services and primary care. On elective, though, considerable work remains to increase activity levels and treat some of those who've been waiting the longest. We've discussed this before, but it will be a multi-year challenge, and a range of ambitions and actions have been identified and communicated to the NHS through the NHS Operational Priorities and Planning Guidance for 22-23 that went out just before Christmas. Supporting that is 2.3 billion of revenue, 1.5 billion of extra capital funding for new beds, equipment and surgical hubs, and diagnostic services will be bolstered by 410 million revenue to continue the rollout of community diagnostic centres and upgrades to endoscopy, breast screening and CT capacity. But it will be necessary, despite all of that, to take steps both now and over the coming quarters, the coming years, to achieve maximum possible productivity in the context of the continuing challenges posed by the pandemic. So no easy task. And as I said, It's not just elective care we're focusing on. The planning guidance sets out recovery ambitions for primary care, community, mental health and learning disability and cancer services too, as well as, importantly, focusing on the key enabling factors like workforce, better use of digital and data, and integration. We continue to see integrated care systems and the structures within them as the primary points of delivery on all of this into the future. As we all know, delays in the parliamentary process have meant that our planning assumptions for the shift in statutory responsibilities for CCGs to ICB has been put back to July, but work continues to support local systems to be ready and to plan effectively for the year ahead. At the last meeting, we discussed how we mirror that integration nationally to streamline the support provided to systems and deliver improvements in care. And I'd just like to thank Mark for the work he's been leading, working with colleagues from Health Education England, NHS Digital and NHS X towards creating a new single organisation. We are still in very early days of that process, and indeed relatively early in our thinking, but already obvious that central to our discussions is how we come together as an effective organisation with the right vision, values and culture to deliver the very best for our patients, communities and people. And I think there is already certainly a real sense of enthusiasm around achieving that goal. Final thing from me, David, I just want to acknowledge, because I think it's important, that we acknowledge the experience of some of our colleagues, particularly women, which were brought to light in the Times last week and on social media and through a range of other channels too, actually. Clearly, the physical and mental safety of every single member of NHS staff is a fundamental expectation, and sexual harassment, assault, physical violence, abuse or bullying should never be tolerated, whoever the offender is. Look, it's not a unique issue to the NHS by any means, but it does not mean it should be tolerated. I did raise this last week, Steve and I, with leaders from the Royal Colleges, because it was an issue that had been highlighted particularly around some of our professional colleagues. And we had a really positive discussion. There was an enthusiasm to work together, including with our People Directorate, to better understand and tackle this problem. And I would just like to say to anyone listening who's experienced this and maybe hasn't come forward, and that, to be clear, is bullying, harassment, assault, abuse, for any reason, anyone who has experienced it and anyone who has perhaps not felt confident enough to come forward, not felt able to raise their concerns, please do speak up. We take this really seriously. We want to root it out, and we can really only do that when we know about it. Steve.
Thanks, Amanda. Sorry, just coming off mute. So as Amanda has said, the whole system throughout the NHS has achieved such a huge amount in the short space of time since Omicron appeared towards the end of last year. But it's also the case that once again we've had to ask lots of colleagues throughout the health service to do things in a different way, and sometimes to do things that they don't usually do, and to focus on particular priorities. So as we come out of this particular wave and Omicron infection rates start to fall, we'll need to begin the process of reversing that reallocation and reprioritisation of staff time in both primary and secondary care, and change from the priorities that have been important and necessary to respond to Omicron in delivering the booster campaign, for instance, and responding to the large number of patients that we've once again had to manage in our hospital systems. So, as I've mentioned, we are now, for example, moving to the next phase of the vaccination programme. Particularly for adults, we've sometimes described this as the hard yards, where we're redoubling our efforts on the outreach and engagement to those who haven't had the next dose of vaccine, including their first dose of the COVID vaccine. So that evergreen offer is still there, and we are still working, encouraging and persuading people to come forward for the first dose, the second dose, the booster dose, and in some cases a fourth dose. But the truth is, it's not going to be quite at the high volume that we saw towards the end of last year in the next couple of months for obvious reasons. And so that means that we are in a position where we can stand down some of that vaccination vaccination capacity, particularly that's been provided by our primary care networks and workforce, and begin to allow general practitioners and their teams to return to focus on their usual activities, for instance, patients with long-term conditions, so that they can continue to get the non-urgent but important checkups that are so important at managing their conditions, but also avoiding potential need for acute care further down the line. So today we have written out to the system once again to inform colleagues of this intention, and we would expect to see that shift, particularly in primary care, over the forthcoming days and weeks. We do, of course, need to bear in mind that this needs to be done in a way that would allow services to be stood back up with a minimum friction in the event of a future need to ramp up the vaccination programme again. But nevertheless, this is the point where we can move some of that work back into usual care. Now, of course, part of this also is contingent upon the work being done with government to establish what a sustainable future delivery model looks like for the COVID vaccine programme. And of course, when government and JCVI decide what the future need is going to be, we will work with them. And of course, the sooner we're able to plan for that, the better we can do so. Same is also true for hospitals in time, although we can't forget that we still have, as Amanda said, very high numbers of patients in hospital with COVID, almost 14,000 patients as we meet here today with confirmed COVID. And as again, Amanda has alluded to, the weekly statistics that we put out this morning showed that the last week was the busiest for ambulance conveyances to A&E since early December. And indeed, those pressures throughout the NHS remain. And in the Northwest, for example, discussions are taking place today around a potential activation of the Nightingale Surge Hub at Preston, at the Royal Preston Hospital, to help with safe discharge and flow for patients in the area around that hospital. And again, I think that really reinforces the continuing impact that COVID is having on the health service and the pressures that the entire system remains under. So as ever, we will be focusing on balancing our priorities in terms of what we need to provide for patients as we come out of this wave, balancing those priorities in the way that clinicians do, frankly, every day in their usual practice, so that we can continue to focus on urgent and emergency care needs of both patients with COVID and, of course, those without, and increasingly that we can ensure that we are putting a real focus and weight behind the work on recovery of elective services once again as we begin to come out of the winter months. I think Amanda, Ruth wanted to say a few words as well. Ruth.
Thank you, Amanda, and thank you, Steve. So first of all, I'd like to say a very big thank you. Thank you to those people that are working extremely hard to make vaccines available for our staff and for the population. Those people working in the NHS, those people that are retired and come back to help us, those people that are student nurses, and of course, our volunteers who have made a huge contribution to the vaccination efforts. The tremendous amount of work that is going on to providing information and support to those that may be hesitant about having a vaccine is hugely important. And I know those are really important conversations. It's because of that work that we are seeing COVID vaccine uptake rates, as Amanda has said, increasing steadily over each day and each week. COVID vaccination for uptake in staff is important, really important. It's important for individual staff members, it's important for patient safety, and lastly, it's important for public confidence, because we know how much the trust the public has in our healthcare professionals. It's right that we now really concentrate on supporting our staff to take up the vaccination. But leaders on the ground are telling us also, and Amanda and I met some yesterday as part of my CNO strategic group, and then I went on to meet my CNO ethnic diversity group. They tell me some of those stories. They tell me too about how compassionate leadership right now is what they're doing to support their staff during these very difficult decisions. So over the last few weeks and months, we've seen and been in a level 4 incident, real pressure on staff. And those leaders also tell me that we don't know where we'll end up with the end of April, by April, with the numbers of vaccine staff, but actually we know that all of our staff are valued and we really want to support them to have their vaccination because we want them into the future. Thank you, Amanda.
Ruth, thank you. I just to add, if I may, just for 1 second, I just think Ruth is absolutely right. I mean, the government's objective of universal uptake, of course, is the right one. And every colleague who takes up their jab is a positive because that means they've got additional protection from the virus. But at the same time, there is a real element of risk in this that local teams are facing, and there's a risk for our national level targets, including the expansion of the workforce, particularly in nursing. So look, just to reassure the board, I am keeping the Secretary of State and his ministerial team informed and up to date on all of these issues.
Amanda, Steve and Ruth, thank you very much for that. It's very reassuring. I wonder, Ara, if I could just throw you a slightly curved ball on this one. You've been a clinician for some 40 years. How would you place the development of mRNA vaccines in terms of sort of science breakthroughs over that time? Will they be one of the major advances you've seen in your time, would you think?
Absolutely, David. It's transformational. What's of interest is something which is very relevant to the NHS is what makes people take up an innovation. In actual fact, mRNA vaccines mRNA technology or the platform has been available for more than a decade and a half. And the challenge has been, how do you translate that into clinical benefit? And I think the pandemic provided, if there is one silver lining, I don't think you can find much, but it's the opportunity to look at platform technologies like mRNA, which is essentially a cargo delivery mechanism. And I think the second big transformation is instead of putting a dead virus, you can actually sequence this on silica on a computer. And I think if I'm correct, by the time the sequencing of that virus arrived to a lab, in 40 days, the first jab was injected into safety trials initially. So that is unheard of. And I think we've all benefited from this amazing innovation. And I think in many ways, the NHS is the best health system in the world that could translate this fairly quickly. And thanks to the scientists and many of the clinicians in the health service, we not only managed to get it into the arms, we got the first patient ever in the world vaccinated in this country, but we managed to expedite the vaccinations at an unbelievable speed. And nice to see the back of it, I hope soon.
And do you think that the vaccines or equivalent to vaccines are going to play a bigger role in healthcare as we go forward in terms of the prevention of illness?
Correct. I mean, the mRNA vaccine, the initial hypothesis of the creativity was actually based on giving someone a cancer vaccine. Which we've seen again in this country. We do cervical cancer vaccines now very effectively in this country, and hopefully in the next decade or so, we see a complete reduction in cervical cancer. So the answer to your question is yes, vaccines will play all sorts of different roles in preventing disease, or at least reducing the sensitivity to whatever that foreign agent might be. It could be a pathogen like a virus, it could be an allergen, which is something which is also challenging us in the NHS, allergies.
Thanks very much, Ara. That's really interesting. And Tim, I think the other sort of, there are no silver linings in this really, but the other big change that's happened over this time, of course, has been the use of more digital technology. Tim, you've now seen what's happening in the US, what's over here. What's your big takeout on sort of how digital has contributed to the recovery over here?
Well, I think, David, we've seen real opportunities taken advantage of because of the crisis. And I'll just say on the supply chain side, delivering the urgent resources, our understanding of that supply chain because of digital resources and where exactly therapeutics like the vaccine are being delivered, that allows us in real time to understand whether or not we're getting to all the people we need to. And when we find we're not, we're able to rapidly pivot. That is how the entire health system should be operating. It's how it's operated with the vaccine distribution program. We have a big opportunity now to have and a big task in front of us. Now that we all have seen that that way of operating that depends on frontline digitization, it depends on data, secure, safe, trusted infrastructure for data interoperability. It depends on our ability to analyze that data very rapidly. It depends on a very low burden of data submission. Actually, preferably, it should all just be automated. I think we've seen now what could be delivered, and now it is the goal of the Transformation Directorate with all my colleagues here to deliver that for the entire service.
So Amanda, look, a huge thank you from the board really to you and your team. I know you've been working 24/7, you know, till well before Christmas. So, you know, thank you, and Steve, Ruth, Tim, everybody else, David, for what you've done. It's been a huge, you know, you've worked tirelessly. So thank you for what you've done. So should we move on to the operations then? David Slobin, would you like to pick that up?
Yes, very, very happy to do so, and thank you. And Amanda and Steve and Ruth, I think, have set the context very well for the performance report here. So, as Amanda reminded us, we did call a level 4 national incident on the 13th of December, and although there are many reasons to be optimistic that we are working through this wave, the Omicron wave, it's worth remembering that we are still in level 4, and there are still 14,000 patients with COVID in NHS beds, so we're still working our way through. If I was to say that the two things which have characterised the Omicron wave compared to previous waves is there has been less demand on our critical care services across the NHS, which in many ways is a consequence of the success of the vaccine programme that we've just touched on earlier. The other side of that coin is because of the nature of the transmissibility of the virus, the biggest hit we have had is staff sickness and absence as a consequence of Omicron, and that's the thing that we've grappled with the most. Now, my report here, David, covers all areas of NHS activity: elective care, urgent emergency care, diagnostics, cancer, primary care, discharge, mental health, learning disability screening, and vaccination and immunisation. And I don't intend going through each and every one of them, you'll be pleased to know, because it's there to be read and digested. But one of the reasons I list those things is, again, building on comments that colleagues earlier, to remind ourselves of the breadth of the services that we provide, and to thank all staff working in all of those service areas for their efforts over the weeks and months gone by. I will just highlight 3 or 4 areas, however. Firstly, on elective care, as board colleagues are aware, we were making very good progress before Omicron turned up in dealing with the elective backlog, and we have had a bit of a pause on that. We did not need to stand down all elective work, although we did have to pause some. But nonetheless, that does still leave us in a position where we have 304,000 people waiting over 52 weeks for their care and 21,000 people waiting over 104 weeks for their care. And we now do need to move into that elective recovery programme as we now move out of Omicron. Some of the data points in the sections on the urgent care pathway bear witness to Steve Powis' comments earlier about the pressure that there has been across the urgent care system. And you'll also note in the section in mental health, that's across the physical and mental health elements of the urgent care pathway. And you can see that data about the increases in the referrals to the mental health crisis service, which is 30% up this year on last year. And also PAMA9 draws out the pressures that we faced within the ambulance service. 2 other things to highlight in the section on cancer. We have been clear throughout the pandemic that our cancer services are there and are open for business, and that anybody thinks they have any suspected cancer symptoms should be presenting themselves for general practice. That message appears to be getting through, because in November, you will note that we saw 117% of pre-COVID referral rates. So those services are there and are being utilised. And I think finally, just to touch on once again the vaccination and immunisation performance, you can see the data there in the pack. So far, we have delivered over 112 million vaccines during the course of this pandemic, which is an extraordinary number. And you can see the data on the first and the follow-ups and the boosters. So I'm quite happy to take any questions on any of the sections I've covered in the report, David. But if that's okay with you, I'll pass over to Peter Ridley now, just to conclude on the financial report before we throw it.
Yeah, just before that, Mark, did you have any comment you wanted to make?
No, thank you, David.
Okay.
David Sloman's covered them. Thank you. So
any questions for David and Mark before we move on to the finance with Peter? Well, maybe David, I could just, and Mark actually, because you've both been chief executives of Trust for many years, and I mean, how if you look back over your careers and just look at the pressure on the emergency service at the moment, I mean, how do they compare with how things have been in winter over the last sort of 10, 15 years in your experience?
Shall I come in first, Mark? So one of the things I think it's worth bearing in mind, David, is we are now in our third COVID winter. When I use those words, third COVID winter, I think that gives us some sense of how hard this has been. It's the consistency that I think has had the biggest impact on patients and staff. And also, I think the three waves to have gone through has been, I think, running hospitals. I would argue that would probably be the toughest time of my career, looking back. Steve Powers and I did the Ebola patients back in the Royal Free back in the day, but that was a very intensive and short period of time. It's the amount of time this has run through where I think has been most telling.
David, if I could just add, I mean, I completely agree with David's reflections there. We talk often about the peaks, but there's a huge amount of activity that goes on when we're trying to recover and restore services, as we have done at earlier stages of the pandemic. And the period of time that we've been, our staff have been trying to respond to the great number of challenges that have come their way. It has been extraordinary, and we're doing our best to support them. And I think the challenge for our leaders in all parts of the country is to make sure that they're balancing a whole range of priorities, and importantly to support all of our frontline teams as well.
Thanks, Mark. And Andrew Morris, you've been particularly concerned, I know, about the that sort of interface between secondary care and social care, and you've also been working within the NHS for a long time. How do you see things at the moment?
So I think for all providers, life is really tough, and you work on a 24-hour basis in terms of managing the flow of work that's coming in and your discharges. So the relationship with social care is really, really important, and trying to get patients out in a timely way is crucial to keeping your hospital going, really. And when gridlock occurs, unfortunately, you end up with delays and ambulances queuing outside of A&E. So we have collectively, with social care, we have to improve our flow through our various systems that both social care manage and we do on the health side. That's not to say that health is perfect. It isn't, in terms of the flow of patients out on where there's genuine straight healthcare needs that need to be fulfilled in other settings. But I think the relationship is really important with local authorities and social care, and it's something we've got to foster for the future. The one pressure point that I'm concerned about in particular is mental health, and I see in the paragraph 29 that there's been particular pressures, and I just want David's reflections perhaps on what we're doing to kind of increase the capacity to match the demand for it, because it's outstripping what was originally envisaged, I think, for this winter.
That's quite happy to reflect back to, and you're absolutely right. And as I referenced earlier, the referrals into the mental health crisis services, which are materially up year on year. So as you're aware, Claire Murdoch is our National Director of Mental Health Services. She is working with colleagues to make sure, as we move into the months and indeed the years ahead, we do have capacity which is aligned both to current and increasing demand. which I think is consistent across all elements of the service.
Okay, thank you.
Thanks. Maybe lastly on this section, I mean, David Bean, you've been involved in social care for many years. How do you see this intersection, or the importance of the intersection between healthcare and social care?
Yeah, thanks, David. So David's point about this is not just a 1 year phenomenon, it's a 3-year phenomenon and ongoing, has been the reality in social care as well. And arguably, the fragility in social care is more acute, and therefore the pressure that has been felt is significant. But I think it's important, David, to look to the future as well, as you said at the top of this meeting. And I think there are opportunities from the learning that has taken place during COVID about where health and local government more generally, but health and social care have collaborated. Then I think communities and people that live in those communities have had improved services as a consequence. So I think the opportunity that there is through the Health and Social Care Bill and the creation of integrated care systems and integrated care boards looking to the future is one that we must take with both hands, it strikes me, because that potentially can change the nature of the game as we go forward. So as we begin to welcome improved figures in terms of infection rates, not everywhere, but in lots of, lots of the country, then I think looking forward to not just continuing to comment on the pressure that we're under, but actually looking to see what the opportunities to design a better future, I think is really important. But just to finally, I suppose, to David Sloman's point, I no longer chair HC1, but I described the couple of years that I did chair HC1 as the most difficult of my professional life by a long way. And we shouldn't underestimate the challenges of delivering services during this pandemic. Wherever in the health and care system we've operated, the challenges are real and significant. But I do think it's important as leaders we look to a brighter future and begin to describe what that brighter future is. And I think Tim's point about transformation and data, Amanda's point about looking forward to the future around integrated care is massively important as we begin to come out of the pandemic. But thanks, David.
Thanks, David. So well then Pat, well.
Yeah, just a quick one, because it's easy to focus when it comes to transformation, innovation, following the sort of pandemic, which forced us to do certain things in a different way. But is it worth just bringing out some of the actual process innovation, some of the ways we've been working to keep patients safe, but challenging ourselves and the regulators to rethink how we do things? So I think that's just as important as well. I don't know whether Steve or Amanda wants to talk about that, or Ruth actually.
Yeah, I think that's a very good point. Out of adversity comes, lots of changes that you would not make in normal times. Pat, did you want to come in? Patrick?
Thank you, David.
Yeah.
Thank you, David. Yes, it's been a remarkable 2 years, hasn't it? And I think the sort of sustained performance over those 2 years has been incredible. Thanks goes to everybody. Really, it's a question for David Sloman, really. Obviously, the system generally has coped very well. Some parts have coped better than others. Could you identify any common characteristics of the more successful responders?
Okay, thanks for that, Patrick. So one of the things I think, it's a bit like David Pryor's just commented about out of adversity, etc. I think one of the consequences for provider behaviour of Omicron has been a much greater willingness for organisations to collaborate and come together and share infrastructure around common problems. So I think the work, Patrick, that we now move on to in terms of how we make better use of our provider collaboratives, how we look at consolidating and specialising some of our surgery, for example, into surgical hubs. I think it has been a much more collaborative approach, which has yielded the biggest dividends over the last few years.
I think that, David, as well, that collaborative approach applies across to the private sector as well. I know not everyone would agree with me on this, but and also, of course, with the pharmaceutical industry as well, on vaccines that Ara was talking about earlier on. It's not, we don't have all the answers ourselves.
Yeah, no, I agree.
Steve Powis, and then Amanda.
Yes, well, I thought I should respond to Wal's question before we sort of passed it by, and Amanda and Ruth might want to come in. So I think the answer is there are lots of changes that have occurred, both large and small, during the pandemic that we need to capture and hold on to because they've benefited patients, have benefited public, benefited staff, and hopefully all three. The Beneficial Changes Network that's been led by Hugh McCackey and the Improvement Directorate has been the program that has looked to capture those and sought individual organisations, systems, and individuals to tell us about those changes. But I think some of the bigger ones that I would mention, and this is not an exhaustive list, and it's in no particular order as they say on those quiz shows. I think the introduction of virtual wards. Again, we've seen programs in this area in the past, but I think the coordinated program that Ian Dodge and the team have led with assistance from primary care and others, I think is something that we really need to think about how we hold on to that model in the future. Much more we can do around avoiding people coming to hospital by providing that in reach of care into people's homes. We talked about the vaccination and the therapeutics program and getting those out at pace and scale. But of course, on drugs in particular, determining what works in a clinical trial is the first step. The second step is getting it into clinical practice. And we know that there's been a frustrating time lag between those two things happening. And so the work of C19, Rapid C19, which has been the collaborative program to get those clinical trial findings quickly into clinical practice in a matter of days rather than months or years, I think has been really fantastic. So we've learned a lot about how we get things into practice quickly. And then, of course, staff have worked flexibly across different systems and across different specialties. And I think retaining that generality of skills rather than just specialist skills, again, something we were focused on before the pandemic, but something that I think we need to capture and do more of post-pandemic. So there's a huge list of things that we're all reflecting on. And of course, the use of data, the vaccine program has been a huge success, not least because its ability to capture real-time data and analyze what it needed to do to improve day on day. And Tim has talked about that, I think, earlier. So I think these are all things that we are taking out of the pandemic and looking to embed in our business as usual as we go forward.
Thanks, Steve. Amanda, then Ruth.
Thank you. I agree with absolutely everything that Steve has said. And I think one of the really important things that he's also said is just this point about not forgetting all of that, but really thinking, how do we build on it as we go forward? Because it will be fundamental to our recovery that we do things differently, that we don't go back to just doing things the same way we used to. It is partly more, but it's partly different. But I suppose two things for me just to add. One, just a note of caution, because Wald talked about processes as well as kind of content things. And I think there is just something for me about, we only have so many staff. So we were able to move incredibly quickly during the pandemic because we had, in a sense, the obviousness of the mandate to focus on the urgent priority in front of us at that moment. So vaccination's a great example. We had to stop doing stuff in order to redirect resource to support vaccination. Similarly, if you think back to the impact on elective, we have had to, because we haven't had the workforce, we haven't had the beds, we haven't had the physical capacity in theatres, etc., to be able to maintain all of that elective work whilst dealing with those big surges in COVID, and it's left a real backlog to tackle. So some of the things that I think we were able to do at pace over COVID, we cannot assume we can operate at the same pace on everything on an ongoing basis unless we're prepared to say it's at the expense of something else. And as we head into recovery, I think that becomes a more and more difficult thing to say, because the agenda for recovery is across so many of those different areas. So I think the caution for me is, yes, we've learned something about how we can move really quickly when we need to, but we shouldn't assume that that is a model of working that kind of is either appropriate, frankly, or deliverable or desirable in a recovery environment rather than a pandemic emergency response environment. But second thing, on a more positive note, I think the things that I would say on process that has been critical has been the way that we nationally have worked in partnership with other ALBs and with other key stakeholders. So I think about, the way that Steve, for example, meets with Royal College presidents literally every week, or now it might be a fortnightly, but it was at one point, I think it was almost every day. And the way that we've worked together across government as well, we're not any of us thinking, I think, anymore that we would do anything in isolation. And that partnership approach between the NHS national team, regional teams, ICSs, local providers is the other thing that I think has been critical to the success of the last 2 years. So the rhythm of engagement, which again, sometimes has been multiple webinars and sessions every week. I'm not suggesting we'd continue to do anything like that, but how we just make sure that we really do lean into that one NHS through all of our different layers, and the one partnership approach across social care, but also across our other kind of key national partners and others, for me is a characteristic of how we need to do things going forward, as well as a kind of critical process reflection on what's worked well over the last 2 years.
Well, thanks, Amanda. And then lastly, Ruth.
Thanks very much. Going back to Wal's question, the one thing I'm very proud of during this pandemic response is how we've cared for children with respiratory viruses. Most winters we see a huge peak in children needing critical care, needing inpatients, and this was a real bit of work that we started back last May and June about how do we take the data from working with UXA, how do we make sure we take the learning from some of the community oximetry at home work, equally some of the digital work, and actually we worked across all 4 nations. So we came together as a UK with clinical leadership, and I've got huge respect for Duncan Burton, Simon Kenny, that have worked together to lead some of this work. But also we've worked with volunteers, with the charity sector, grateful too with HE partners, with James developing the training programme for paediatricians and paediatric nurses. Actually, it's that collaborative working that all of us coming together has been working in partnership, using data, but at pace. And I think that's the type of transformational work that we can do into the future. And indeed now, I was only talking to the team last week, and we're planning now for next winter.
Thanks very much, Ruth. So shall we move on then to the finances, and then after that, the planning guidance? That's you, Peter.
Yeah, that's fine. So on the finances, it's in the paper, so I won't say an awful lot. We're forecasting to come in within core budget. So we have a surplus of 1.3 billion on the core NHS commissioning and provider budget, and that's against a plan of 154 billion. So as well as efficiencies, we're seeing there is certainly the impact of operational pressures and Omicron, meaning that we haven't been able to deliver all of the investments we would have liked to, and have had to defer some programs. So that is partly driving the surplus we've got there. Finally, just in terms of provider capital, we're forecasting a small underspend on the provider capital, and are working through that at the moment. So we're on track on the finances. So there's probably not an awful lot more I'll say than that.
Did anyone have any questions for Peter on the finances, or can we move on to the planning guidance for next year, Peter?
Yep, certainly. So you've got the paper in the pack, and it's there to note. So just to summarise what you've got, it's the operational planning guidance. So the board's previously discussed the NHS priorities and planning for next year, and so this is pulling together where we are. The main planning guidance, as Amanda described, was published on the 24th of December, and so the process of planning out in the NHS is underway. That will consist of draft plans by the middle of March, and then final plans at the end of April. We are still working through some of the detailed technical guidance, and that's being finalised with government, so that'll be published in due course. The paper summarises how we're going about setting the budgets and planning, and it reflects the spending review settlement announced by government. You'll see the approach is the one we've discussed of moving back towards a more normal business as normal framework. in how we operate the financial regime and how we go about managing the finances of the NHS. And the shape of the resources we've got described in here, and again consistent with the spending review, is an expectation of lower levels of COVID demand, so lower additional COVID costs, but with that tapering over a number of years. So table 1 describes the tapering of those non-recurrent COVID costs, distorting somewhat the comparison between years, but that's one of the big swing factors. In line with how we'd go about a normal financial framework, we've described some of we've described how allocations work and how fair share target allocations have been updated. So as we would usually do, we've taken the recommendations of the Independent Advisory Committee on Resource Allocations at ACRA and built that into how allocations will be made down to a commissioner and place level. Finally, the paper goes on to describe some of the things we've already discussed in this meeting, so continued commitments to mental health, primary care and other areas, as well as the deployment of additional resources for elective recovery. And it's clear there's an expectation that we'll increase the delivery of efficiency. We'll take out some of those elements of COVID costs we've already described. We'll restore productivity levels and we'll continue to recover elective performance with the dedicated resource we've got to do that. So that's probably the broad summary of the paper. And as I say, it's to note here to bring together where we stand as of today.
Thanks, Peter, very much for that. Did anyone have any particular questions for Peter? One sort of general question, maybe the question is best for you, Amanda, or David or Mark. But I haven't actually walked around for obvious reasons a hospital recently because of infection control issues. But if you take a sort of one of our older hospitals, where there's very few single rooms, where entrances into A&E are sort of compressed and sort of probably only one way into A&E, how would, in terms of the impact on productivity and sort of in one of those older sort of DGH hospitals, what is your general view about that?
I wonder, David, if it would be worth bringing Pauline in on this, because Pauline's done an awful lot of work with hospitals on exactly these sorts of constraints. And indeed, Ruth might want to comment as well in relation to infection control. But I think you're right to raise it because, I mentioned a moment ago, we've only got so many staff. Well, we've also only got the estate we've got. And that is a kind of significant factor in what, of course, we're now able to do. But perhaps if Pauline wants to come in.
So yes, David, I think Steve probably commented in one of our recent meetings that if we had an NHS estate that had all single rooms, our ability to cope and to be able to continue care during COVID would have been different to what we've had experienced. And Ruth might want to say a little bit more about that. So from that perspective, if we could imagine a situation tomorrow that the NHS was suddenly single rooms throughout, then our ability to cope with future COVID waves would be different. The flow through our hospitals would be different from a UEC point of view. We'd be able to maintain a lot of our elective work. So clearly having a big difference. But I think it's not just things like single rooms. It's if we just look at right from the front door of our hospitals through, so many of our emergency departments, and over the years, I think I've just been in all of them and in some of them on a regular basis, are really probably not very different to what they were many, many years ago. Now, clearly, year in, year out, we are upgrading, etc. But we're trying to do what we can with the estate that we've got. Those emergency departments that have got cubicles that are like glass cubicles, for example, you will see them in Leicester, etc. Again, from an IPC point of view, very different, and how we can flow our patients through. But I think it really covers just about all aspects of the NHS estate. And I think out there, people are doing their very best year on year to try and improve the environment for our patients, to give them better privacy and dignity and everything. But it's also important from a productivity point of view.
Can I comment then, David? So yeah, absolutely. We know that where people have had more single rooms, they've been able to cohort patients better, safer, less nosocomial transmission, but also those people who've got bigger EDs. There's lots of our organisations that have got emergency departments that were built for the number of patients going in them 10, 15 years ago. So those people that were bigger EDs, those people got more space in between the beds, and of course the ventilation. So yeah, the new hospital programme, working with Natalie Forrest and colleagues there, but absolutely single rooms and the estates, investment in estates will be one of the big learning for me out of this pandemic with regard to infection prevention control.
I think of the old hospital that used to be chief executive of, Ruth, if you remember, in King's Lynn.
Very lovely Queen Elizabeth Hospital, King's Lynn, absolutely. Great
Lovely.
staff, but needing that investment in the building, aren't they?
It was needing investment when you were there, and that was
Indeed.
quite a few years
Some
ago.
time ago. Don't age me now, David, please.
Is there any questions for Peter that anyone would like to raise? Otherwise, any other business that anyone would like to raise, or shall we call it a day? Good. Well, look, Amanda, thank you very much. And for the next public meeting, we'll have a few other issues on the agenda. But in the meantime, thanks to you and your team very much. Goodbye.